Simon.
Nice to meet you.
How do you do? I'm Ian. I'm a medical student. I'll be performing the respiratory exam on you today. I'm just going to wash my hands. So when performing the respiratory exam, we follow the traditional pattern of inspection, percussion, palpation, and auscultation. I will begin with inspection. In the case of Simon, he said looks to be a young, healthy individual. Typically with inspection of the pulmonary system, we'll be wanting to look for signs of various pathologies. We can get an impression of his respiratory rate, whether he's in respiratory distress. We can look for accessory muscle use, the scalene and sternocleidomastoids. Simon, can you hold your hands up for a second? We can also have a look at Simon's digits, inspecting for clubbing. Simon, can you bring your two ring fingers in together like this? We check for clubbing. And can you bring your gown down just to your waist, if you don't mind?
Sure.
Expose the chest. See that there are no massive scars or lesions. We can get a better indication of chest diameter with this, and whether there is in fact barrel chestness in the anterior-posterior dimension. I'll also have a look at the back. We see that Simon has a small scar on the back. Did you have any surgery, or was this associated with?
You should have seen the other guy.
I see, okay. Following inspection, we'll move on to percussion of the chest. So I'll start off with Simon's anterior chest. We'll notice as we get to the area of cardiac dullness, there is an asymmetry, which is in fact normal, and there's in fact a physical sign that can be predictive of chronic obstructive pulmonary disease is resonance on the right side of the area of dullness. So Simon, I'd like you to swing your arms around the side, legs around the side, sorry, and we'll proceed to the back. And again, always listening on either side, trying to appreciate dullness in opposite lobes of the lung. Another important aspect of the physical exam is general palpation, particularly in the context of possible rib fracture. That can involve just palpating throughout the lungs. Any areas of tenderness?
No, thank you, Simon.
Another movement that's classically taught in physical exam of the chest is chest expansion to look for asymmetries in terms of during tidal inspiration, or perhaps an asymmetry on account of an effusion. So what we do, we grab some skin. Simon, can you take a big deep breath in? And release. We see that there is symmetric inflation of the lungs and expansion of the chest.
Now I will be demonstrating tactile fremitus. In order to do this, you'll want to place the ulnar surface of your hand on the patient's chest and have the patient repeat a phrase such as 99 or boy oh boy. And remember, don't forget the apices. So Ian, can you please repeat the phrase for me? 99.
99, 99, 99, 99, 99.
Again, while the patient is doing this,
99.
It's important
99.
to compare what you feel on both sides to gain an appreciation of any consolidation or pleural effusion.
Finally, the most practical and most commonly used aspect of the physical examination of the chest is auscultation. So typically, again, we would like to perform both anterior auscultation of both the anterior and posterior walls of thorax. Again, appreciating the apices. Simon, can you breathe in and out just with your mouth open, actually? And ideally, if I knew the boundaries of the lung as I'm auscultating, I would be describing to the examiner the various characteristics of sounds I'm looking for within the various lung lobes or borders. And I'm not appreciating any sounds such as crackles, wheezes, stridor on the auscultation of Simon's chest.
So now I'll be checking for whispered pectoriloquy and egophony. So, Ian, what I'm going to ask you to do is, can you please repeat the phrase 1, 2, 3, and can you whisper that phrase?
1, 2, 3. 1, 2, 3.
Okay. If the patient were to exhibit whispered pectoriloquy, I would hear a difference in the sound on one side versus the other. Now I'll be demonstrating egophony. Again, Ian, this time can you please just make the sound E when I'm listening on your chest?
E, 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 E.
Now we'll be demonstrating diaphragmatic excursion. So the first thing we want to do is, because we don't know where the diaphragm is just, Ian, I'm going to just percuss your back and get an idea of where your diaphragm is to begin with. Again, we're expecting this to be at about the level of T9. And so where the percussion goes from resonant to dull, we can say that this is about the level of the diaphragm. So Ian, can I have you take a deep breath in and hold it? And now I'm going to percuss again until I find the lower level of the diaphragm. Okay, thanks, Ian. You can take a breath out and just breathe normally. And what I'm going to do here is just mark that level so I have an idea of where the lowermost level of the diaphragm is. Now, Ian, can I have you take, what I'm going to ask you to do is to take a deep breath in and then a deep breath out and hold that deep breath out. So deep breath in, deep breath out, and hold it out, hold it out, hold it out. And again, okay, that's great, you can take a breath in. And again, I'm going to mark where the percussion transitioned from resonant to dull, which is approximately here. And now we can measure the distance. This will be the diaphragmatic excursion. And just on inspection, that you could do this with a ruler, we have a diaphragmatic excursion of approximately 4.5 centimeters, which would be in the normal limits, which is about 3 to 6 centimeters. Any deviation smaller or higher would indicate some sort of pathology.
So that, for the most part, concludes the physical examination of the chest. The end.